Okay, Ben. So I'm going to get this webinar started. I was about to say podcast, but it's not a podcast. There's a webinar. I want to thank everyone who's turned up. So with me today is Ben Lindsay, and he is a biomedical engineer, not biomechanical, biomedical engineer.
Yep.
And he is one of the brains behind Solushin, which is a device, a medical device used for treating shin splints. So Ben has also been, if you missed the episode, on the Podiatry Legends podcast, episode 124, Ben was on that. And he's now been on a number of podcasts talking about the same subject, about treating shin splints with Solushin. So Ben, I'm going to hand it over to you. And
thank you, Tyson.
If anyone has any questions, please just put it in the Q&A box or in the chat box, whichever works for you. I'll see both. And I'll pass the questions on to Ben if he's in full swing. But I'll probably interrupt a few times anyway, because I always have questions. So Ben, over to you.
Awesome. No, thank you, Tyson. And then for anyone with your Q&As, just shoot your questions through. If we run out of time, I'll ask Tyson to try and get a copy of them to me, and then I can try and send them out to everyone. And look, so a bit of background on me, just while we get started. So as well as being a part of the solution, so I am a biomedical and mechanical engineer. So my primary focus is looking at how research can translate through product design to assist clinicians in treating patients. So that's my focus. I majored in mechanical engineering with the biomedical to be predominantly looking at sports medicine and orthopedics. And that's because I was an athlete. I used to do oil and gas engineering. So I used to be doing a bit of the devil's work, so to speak. But I didn't enjoy it. And I thought, this kind of stream of engineering would enable me to help athletes like I now used to be. So since founding Solushin and developing the product and looking into the research, I've been fortunate enough to help out with a few CPD programs for podiatrists. I've been trained by New South Wales Health in medical device commercialization. And then for my biomedical engineering endeavors, I've won a few design and innovation awards. And it predominantly just comes from making sure I don't just look at the papers and the research, but going out there and kind of putting my feet to the floor and talking to a lot of people that it's going to affect and how that research translates into clinical practice. And then I'm also spending a couple of days a week as the program manager at the University of Sydney, helping their researchers, anything from quantum computing through to genomics, translate their ideas from a napkin to in some cases, ASX listed companies coming out of the University of Sydney. So that all said, the highlight of my career so far is admittedly getting my Podiatry Legends podcast t-shirt, which Tyson's seen me spruik around on social media. Oh, and as Tyson mentioned, I was on an episode, but it's definitely the t-shirt that I like wearing around the shops here in Sydney.
And did you get a t-shirt from the other podcast that you've been on?
No, I didn't. They're all stingy.
There you go.
But did your participants or your interviewees, did they give you a t-shirt, Tyson? Because we also know that particular shirt's one of your highlights. I'm hoping.
I have received some gifts from some gifts. I've got rum. And so I have got some spirits, but the t-shirt was really
personalized. This is completely unique. There's not another one out there on the planet. So it's got to have something. So in today's agenda, I'm going to go through why MTSS. So looking at, what the motivation is behind doing this, what it is. So MTSS, medial tibial stress syndrome, just to inject that, commonly called shin splints. So what is MTSS? The diagnosis, differential diagnosis, best management practices, how the solution fits in to that, being a piece in the puzzle, running through the clinical studies we've completed, and then also just a little bit about what's next for us. So starting off with why MTSS, so why medial tibial stress syndrome. Now, we're a team of athletes. So myself, I was a swimmer. William, who's now an orthopedic registrar in Wollongong, he was a runner, and Rosa was a gymnast. Rosa's claim to fame is she was Tasmania's first finalist at the National Opens for gymnastics. Will, national finalist, and myself, national medalist and World Cup representative. Now, even at the levels of sport we managed to achieve, there's quite a few little injuries out there that still wore athletes down, and there was no real reliable kind of treatment source other than rest and a slow recovery. And there was a huge mental burden for all three of us when it came to medial tibial stress syndrome. So we've all suffered from the injury, and we all had the mental burden of being sufferers of that injury and trying to achieve greatness in sport. And it really highlights that for you as the practitioner, the podiatrist, that overuse injuries like medial tibial stress syndrome have a huge mental impact on athletes. And it's something to consider when treating the injury. Just to make that more substantial and to kind of avoid our own bias, we actually spoke to 500 runners in a 13-week program with New South Wales Health. So that's just the early Saturday morning park runs before COVID. And we basically just asked 500 runners who'd had medial tibial stress syndrome, what does it mean to get that injury? And, you know, the responses weren't my legs hurt, you know, or I couldn't train as much. In fact, there was quite a big mental burden on them. So without running, their lives felt pretty empty. Some of these runners, particularly weekend warriors, are running for mental health. And when they get these injuries, it's crushing them. And then on the more professional side, it can completely ruin a season. And, you know, I know there's often the joke that athletes can get wrapped in cotton wool and they can kind of go through a bit of emotional turmoil. But after years of trying to train and compete at a certain event, to have a season lost, there's a huge mental burden. And I think that's why it's important with injuries like MTSS to work out ways to treat effectively and to treat quick. Of those 500 runners, MTSS affected 16.43% of them, the most of any other injury as well. So the mental burden and the size of the injury in runners, particularly all these runners were here in Sydney, basically is the answer for why we were interested in MTSS. So before we move on, Tyson, do you have any questions about why?
I'm in deep thought. I'm actually listening.
Yeah, awesome.
It's good to sit back and just listen for a change instead of like when you're the host of a podcast, you go backwards and forwards. It's good to just sit back and just take it in.
Perfect. So
I will ask the question. So the 500 athletes that you actually had, was there a criteria based on age? Did you have any criteria in picking those 500 athletes?
This was basically just kind of like market research. So we spoke all the way to Olympic finalists through to anyone at a park run, basically who wanted to chat. And I think the reason we did that is we weren't looking for, so we were just looking for generally healthy people, and basically across the spectrum, did we see any changes? Because our hypothesis actually was a weekend warrior is not going to feel the impact as much as an athlete who's trained for years and then they lose a season. But in fact, we heard a lot of other things come through, which was quite an eye-opener for us as a team. So,
and what about, if I ask another question, just before you get into this, what about distance-wise? Did the 500 people, were they 5K, 10K, long distance runners? Was it any?
No. So we had a 400-meter runner, we had a 100-meter, 110-meter hurdler, all the way through to just people doing a park run once a week. So there was the purpose in this was just to capture what medial tibial stress syndrome means across the broad population of runners, whether they be elite professional athletes competing at an Olympic level, all the way through to, just running for general fitness. And what we kind of proved out there, what we didn't intend to actually prove out, what was shown to us was actually the weekend warriors, a vast majority of them were running for not just fitness, but for mental health, and not just for MTSS, but other overuse injuries. The impact of not being able to run was actually greatly felt, actually a lot more than we thought it would be, if that makes sense.
Yeah, no, that's fine. Okay, that answered those questions.
So what is MTSS? So medial tibial stress syndrome, more commonly referred to as shin splints, or one of the terms that kind of falls under that shin splints umbrella, aka pain somewhere along the shin bone or near the shin bone. It's an overuse injury that affects up to 35% of running populations every year. Now, I've highlighted that in blue just to preemptively make sure I say, I haven't seen it that prolific. Now I've spoken to a lot of clinicians, and I know I've seen researchers like Joshua Maddock, I think, hypothesize it's probably closer to around 13% in those populations. But nevertheless, it affects a lot of runners. The symptoms best described as a persistent dull ache along the distal third of the medial tibia, aka shin bone. So the main thing I really want to highlight in this slide is that treatment is limited, and unfortunately treatment hasn't actually developed too much in the last few decades. The pathophysiology of MTSS, so it's really kind of poorly understood. So first off, it's a syndrome. So as soon as we hear syndrome, we start to think of things being maybe multifaceted in terms of the issue, so not just one thing, and making things a little bit more complicated for us to understand. It's potentially a spectrum, which we'll go into on the next slide, but predominantly what the hypothesis seems to be is the periostitis and the disruption of the Sharpie's fibers. So if we see the periosteum here, as we get inflammation and the periosteum begins to kind of tent, so like tent off, what we see is this traction and pull on the Sharpie's fibers, which tend to tear off the bone. The other pathophysiology theory out there is the tibial stress reaction. There's also the note of periosteal and bone remodeling, which I'll get into in a little bit later, and the myofascial pain disorder. But the key thing on this slide, what's kind of worthy here to look at, is just the interplay between the periosteum and Sharpie's fibers into the bone. More research is definitely required into this, and as a team, even though we're product developers, it is actually something we're trying to organise here in Sydney at the moment, so a more in-depth pathophysiology clinical study. So if we're looking at that spectrum note, so in terms of bone loading, what we can use here to kind of understand it visually is called the Fredrickson classification system, and it really gives us kind of like a nice visual understanding of what's happening under MRI. Right, so, we've got grade 0, so a normal tibia. So as soon as a runner starts to undertake excessive load, an excessive load meaning that bone is being broken down at a rate greater than it is being remodeled and formed, the bone starts to undergo a stress response. So grade 1, we start to see a periosteal edema, or we commonly note it as periostitis, that inflammation of the periosteum. Grade 2, under MRI, we start to see this bone marrow edema forming, right? So this kind of little trauma, or not trauma rather, so these effects under MRI appearing internally. And then as it progresses and the runner doesn't address this excessive loading, the bone begins to deteriorate. And we see what's called under MRI an intracortical signal change. If we were to kind of visually describe it, imagine you've got a limestone block, and then in the limestone block, you're looking at it, but imagine you could look inside of it. You've got two next to each other. You've got a solid limestone block, and then you've got a limestone block with all these internal tunnel networks, right? Almost like an ant's nest kind of forming in between it. Now you take a hammer to the limestone block, which is completely solid. You might just hurt yourself, might cause a bit of reverberation through your hand. You take it to the limestone block that's beginning to hollow out and you hit it, you start to realize as you basically hit through that layer and it crumbles, that there's been a big deterioration. And as we see under this MRI kind of image here, or not MRI image, this classification system, we can basically get an understanding of why we start to issue these stronger stress responses and stress fractures as the bone deteriorates. So as well as bone loading, the other kind of theory to look at, which we definitely like looking at, is this notion of MTSS's association with a myofascial pain disorder. So myofascial pain disorders, quite common actually, quite commonly known. So muscles with activity or injury related pain, what we tend to see is they're usually abnormally shortened with increased tone and tension. The easier way for me to call this out to memory is trigger points. So when you get those painful nodules in the muscle, those almost like lumps as you rub your thumbs over, maybe you've also been the victim of a massage and the massage therapist has hit those trigger points and you know how it feels. They're hyper irritable, and they are composed of hyper contracted extrafusal muscle fibers. So everything kind of just balls up together in a tight knot as well. So muscle knots, kind of another notion to think about. How you treat myofascial kind of these nodules, they're mechanical, thermal or chemical treatments can work. And by focusing on those kind of treatments, it can result in reduced pain and temporary resolution of muscle over contraction. Now, the reason we're kind of highlighting these bone loading and myofascial pain disorder points, as we'll get into on the next slide, is because I often meet practitioners who focus on one or the other when it comes to medial tibial stress syndrome. So they're often thinking it's either bone loading or it could be muscular, it could be myofascial related and soft tissue related. But my big thing, which I always say to them is, "Per cornelis dos, why can't it be both?" And it really comes to the analogy of the road bike and the downhill bike. Now, let's just look at it as a bone loading theory and imagine it's just bone loading. Let's take this road bike here, the Merlin, and imagine, for any of you who've done some off-road downhill cycling, imagine you're tackling that track on this Merlin, right? So you've just got the frame. That's the frame and the wheels. The only kind of shock absorption is probably the little bit of useless rubber around the wheels. What can we expect to happen? Right, so the loading, your bum might get a little bit sore. It's not going to be very comfortable, but you could probably expect the frame of this bike to crack because there's no way for it to distribute the forces it's encountering as it goes down. Whereas with downhill bikes and mountain bikes, we see they have a frame and they've got shock absorbers. These shock absorbers help keep the frame intact and keep your bum nice and comfortable when encountering the forces. What we don't see is a bike with just a suspension kit and no frame. So this little downhill bike is the kind of the analogy of what I want you to think of when we look at this next image of the muscles and the bones interplaying in the calf. So we have the frame, we've got the tibia, just to highlight one of the bones that we're predominantly looking at. We've got the tibia as the frame, and we've actually got the soleus as one of the shock absorbers. Now, all of these muscles are related the gastroc as well as a shock absorber and helps with running. But the soleus, if we're looking at how much force that is shown to absorb in a runner, we start to see numbers like 8 times body weight per stride in a mid-distance, I believe, to long-distance runner. And that's why, sorry for going on to the next slide. So that's pretty much why I think they're both related. And I hope that analogy helps. Tyson, do you have any quick questions or maybe how I can, is there any misconceptions there for you that I can touch on?
No, but I do like the analogy. I love the analogy between the two bikes. Even if you've never ridden one of those bikes, just visually it makes sense. But I have ridden both bikes, and I've tried riding a road bike down a hill, and it's not comfortable at all.
No, well, it's just an easier one for people who've just ridden a road bike is those times you've just maybe gone down a curb or you hit those kind of cat eyes in the road and you're sitting down. It's enough to hurt your bum. There's no ability to absorb the shock there. So it's why it's both. It's a simple thing. It's a simple analogy for us to explain. Well, the tibia absorbs the load in one way, but if we can ensure the soleus is functioning and all the surrounding muscles are functioning correctly, we've got shock absorbers that can work together with the bones. Now, MTSS presentation, touching back to what MTSS is, so we're starting to see or hear of diffuse dull aches in the lower legs. So pain, is often described as, by athletes is my shin hurts, is kind of an easier way to understand it. But the way for you to kind of get a clear understanding of what's going on is this tenderness to the distal third of the posteromedial tibial border. So, generally if you, as the podiatrist, you start touching and palpating along that area, it will be very nasty, or the athlete will be able to tell you, or the patient rather, that it's sore to touch, right? So the key thing here is that it's sore to touch for a distance. We're not talking about a focal pain, which we'll get into later. We're looking for a distance of pain along the border of the shin bone. And, generally, which we'll go more into in the diagnosis, the anterior border doesn't tend to be tender at all. But for this MTSS presentation, athletes tend to walk in, my shin hurts. If I touch here, I'm quite sore. Who gets it and why? So in the literature for the general population, 4 to 20%. 35% in the military population for reasons I can only hypothesize, we get a mix of recruits coming in to the military, some from a background of eating pizza, other from a background of getting fit, ready to join the military. And then also very high incidence rates with female netballers and hockey players. So risk factors, these aren't all the risk factors. These are just some worthy of note. Regarding bone loading, we start to see female athletes suffering more there. The risk factor of running on hard surfaces, running at too high a volume too soon, having a high BMI, and back to this significant changes in volume surfaces or loading that I'm sure we're all familiar with. So that's regarding the bone loading aspect. Regarding the fascial traction, we start to see this risk factor of increased midfoot pronation and associated gait patterns, and reduced ankle dorsiflexion and soleus muscle tightening. So in particular, the ones I want to, if you're going to remember, say 2 of them, what I want you to really think about is in the bone loading, this significant changes in volume, surfaces, and loading when treating the injury. And regarding to the fascial traction, this reduced ankle dorsiflexion and soleus muscle tightening. So continuing on with who gets it and why, we've got the athletes, we've got military. Female athletes and female patients tend to be more predominant than males. A lot of weekend warriors, just because of that volume control, that need to get out there and do stuff quick. They haven't had that slow build. Netball and hockey players, female players, footballers at transition periods. And then like myself and my friend Mitch here, who's on the right. So Mitch was a Commonwealth Games swimmer, but for New Zealand. Sorry, Australians. Swimmers on land. So as soon as myself and Mitch decided to transition from the water to land, this is almost like an evolutionary picture here for Mitch, we started to fall apart. So moving on to diagnosis. So to how to diagnose the injury. So great way to do it is actually, in our belief, not to predominantly rely on imaging, but clinical presentation. So firstly, looking at the patient's history. So have they got a history of reporting this diffuse dull ache in the lower leg? Are they complaining about it commencing and completing it during exercise? Sorry, generally at the commencement or completion of exercise, or both. But something for you to do is in clinic is a simple exam, really. So we're looking for non-focal tenderness, palpation along that distal third of the posterior medial tibial border. So touching down with your fingers, and we're looking for at least 5 centimeters, right? So we're not looking for focal pain. The tough one here is to understand that obviously some people have much shorter tibias than other. So the takeaway from this at least 5 centimeters is just the non-focal pain. We're looking for it over a distance. And then another test, which I've actually never done or seen done, but according to the literature, and I'm talking to a lot of clinicians, a great way they verify it is the pain with hopping on the single leg. Now, a disclosure here for the diagnosis of medial tibial stress syndrome. It's a tedious injury to diagnose and is often an injury that is diagnosed correctly by ruling out other potential injuries. Now, this is a tedious one. So I'm a biomedical mechanical engineer. So I'm going to help out a bit here with a resource that I really like to use to help convey to clinicians. Now, it's an interesting article that a lot of people probably won't look at because it's about popliteal artery entrapment syndrome, but it's done by Matthew Hislop and the rest of his research crew in Queensland. It's got this brilliant table in it. Table 1, differential diagnosis and clinical features of exertional leg pain. And what we see here is all the common differentials for MTSS diagnosis. So MTSS itself, how we can diagnose it. So we can start to look at the unilateral bilateral tendency. So we do commonly see bilateral pain for MTSS sufferers. Its incidence rate is very high in comparison to some of the others, excluding exertional compartment syndrome, so chronic exertional compartment syndrome. Site of pain, posterior medial tibial border, pain present at rest, yes, on palpation. And then also this little column here, which is very useful, is how is the pain also presenting during activity. So pain with activity can warm up and return on cessation. So runners tend to experience MTSS pain at the start or completion of exercise. Stress fracture, which we'll get into a little bit after this slide. Now, stress fractures incidence rates are much lower and very unknown, actually. So as we see here, this massive kind of gap of 0.7 to 20% of the exercising population might be having stress fractures. It's possibly female, usually unilateral, so just on the one leg, and the site of pain really varies depending on the site of the stress fracture. It is also sore on palpation, so calling back to the 5 centimeter rule, so trying to rule out that focal pain. And the pattern of pain, it's predominantly sore upon impact. Now, just the last of the ones that I'll go into more detail here is the chronic exertional compartment syndrome. Now, incidence rate of this is quite high. You know, we don't know if it affects male or female, females more. At the moment, it's looking pretty equivalent. You know, bilateral tendency. Now, the side of pain is where we start to see the clearer differentials. So we often get that anterior pain. So around the tibialis anterior, the lateral compartment. It's also called lateral compartment syndrome across some clinics, or the deep posterior compartments, with the anterior compartment being, as far as I'm aware, the most predominant or the most common one. Pain present and at rest? No. So you don't get that pain on palpation. And now what we're looking at here is this pattern of pain is the crescendo decrescendo pattern, which can last for minutes to hours. So, you know, the slow increase and then the very slow decrease. Now, popliteal artery entrapment syndrome, for this anatomical and functional components here, go look at the paper. It's very good for ruling out these differentials. But just for the sake of this, these top three seem to be where I get the most common questions. I'm going to address stress fractures a little bit more though than the others, just because it's, as we'll go into later, a big contraindication of the solution. And often it's probably the most common question I'm seeing in clinics. So look, they're not very common. You know, thought to represent 0.7 to 20% of sports medicine clinical presentations. The pain, really going to hone in again, is focused on a certain site and is sore to touch. And then, as we saw on the previous table, it hurts on impact. We often see pain presents early during that impact-related exercise, and again, is worse during the landing phase of running. So here, it's really talking about your patient's experience and how they've been experiencing pain before attending clinic. You know, they're typically unilateral. So if you've got a patient presenting with bilateral symptoms, you know, it's not as common. And then it can affect any bone in the lower limb. It's just tibia is the most common. And then the last point takeaway from this slide is the female athletes are thought to be at a greater risk. You know, there's a lot of theories behind this. There's menstrual disturbances, caloric restrictions, lower bone density. The list kind of goes on. But just calling back to the Fredrickson classification system, we start to see that overall, to have these stress responses, according to this classification system, we're looking for sustained excessive loading on the tibia, leading to that stress response. Management. So this is going to be focused on the management of medial tibial stress syndrome. I haven't seen any questions come in about the diagnosis and differentials. Tyson, did you have any?
Yeah, so if anyone's got any questions about that so far, just, yeah, you can raise your hand or just put something in the Q&A box. If not, just move on. No, everything's been made sense so far.
So now onto the management of medial tibial stress syndrome. So this comes back to my earlier point of treatment being pretty limited. So when we started this out, the treatment that we found, icing, icing painkillers, basically anti-inflams, seem to be the general go-to for a lot of athletes. Going more into podiatry and physiotherapy programs, you know, massage, particularly of the posterior chain, seems to be quite helpful. Stretching, strengthening, and gait retraining. So this little note here isn't to highlight that it's not the way to go. It's just to highlight that there's 2 RCTs out there showing that there's no significant effects from strengthening, gait retraining, and stretching. However, they're in military populations. We haven't seen one in a general population yet, as far as I'm aware. Load management. So this is probably my favorite. If I was to, I think I said it on the episode with Tyson, if I was to tell you there's a hot dog out there and a lot of condiments to treat medial tibial stress syndrome. I think load management's the hot dog, and everything else is the condiment. So you've got your ketchups, mustard, and relishes. These tailored running programs for the patient. So decreasing distance, frequency of running, the intensity, and having change-ups of the surface. Another way to address or to target this load management, neoprene insoles. So if you can visualize hitting a stick vertically into the ground and the stick buckling and breaking, imagine the stick has a little cushion at the bottom and you're hitting it with the same force at the ground. It's just a way to deload the stick, help it be more resilient. And then also there's evidence out there for semi-rigid custom insoles and orthotics. Again, all of this, which I'll harp on about quite a bit, it has to be very patient specific. So you can't do a one size fits all treatment program for MTSS. You're going to want to look at the individual patient. Now, there's limited evidence for calcium supplements. There's a study with the military population, limited evidence for laser therapy and extracorporeal shockwave therapy. Now, this is a common one I'm asked about, and my answer to everyone who gets results is if it's working for you, great. Like, why stop if it's working? Some clinics aren't seeing the positive results, and for them, that's unfortunate, but there are plenty of clinics who are seeing good results, not just for MTSS, but for Achilles tendinopathy and plantar fasciitis. Other limited evidence for acupuncture, PRP, ultrasound, whirlpool baths, electrical stimulation. However, in these groups, we're not seeing any RCTs focusing on MTSS, with this little disclaimer that I saw. So if you find one, my contact details will be at the end. If you see anything in this treatment, kind of these slides, please send them through, because not only do I try and go out there and encourage the use of Solushin, I try and give people a better, well-rounded, overall holistic treatment program.
I was going to say that. So anyone that's watching this or watching the replay afterwards, if they have used the treatment themselves really successfully over a period of time, you're cool with them reaching out to you afterwards and just saying, "Hey, I've done this."
Yeah, definitely.
And sort of talking about it a little bit more detail. So you're open to other people that have tried, because we treated a few patients with shockwave, and we got some patients that worked well and other patients it didn't make any difference.
Yeah, no, it's definitely, it's a common story. And I think one of the things with shockwave right now is it's just the limited evidence in terms of like, I know there's, I think if I say this wrong, don't hold it against me. I think there's another, I think it was done by Moen et al. That's how I remember researchers, is how I've cited them in terms of research groups. I think they've done a shockwave therapy study of shockwave and load management versus load management. And I think they saw an increase. It might not have been that research group. So there was that study there, which looks promising. I think just when I'm talking to clinics as well, just to highlight some, honestly, they get great results and others don't. So I think for any treatment you're doing for MTSS, if you've been seeing results, you should really stick through with it and keep going, because that's great. I don't think it's worth people getting caught up on who's got the best treatment and who's wrong. I think if we're focused on delivering positive outcomes for the patients, that's got to be first and foremost. So if you're seeing positive outcomes for the patients using X, Y, and Z, doesn't matter what other people see. I recommend you be open-minded to see how you can improve, but keep doing the things that work for you.
Okay, that's good.
Common question, some recommended exercises. Now, I recommend you Google the muscle groups. This isn't my strong point at all. I am fortunate, so I was always wrapped in cotton wool and given stuff by great strength and conditioning coaches. Nikolai Morris recently did a presentation on medial tibial stress syndrome. She's now betrayed me here in Australia and gone over to New Zealand. So we're looking at the soleus and gastrocs, the tib ant, the tib post, the FHL, the perineals, core, and hip abductors. Now, I'm going to disclose that I actually am not the best person to talk to you about this. It's just this common question I'm given. So I'm trying to go, here is something for you to look at. So these strengthening exercises, I know for the soleus, if we're looking at soleus dysfunction in terms of weakness, The bent knee calf raises are a go-to, and the gastroc are the straight leg calf raises. But for everything else, I definitely recommend you reach out to a good S&C coach in the area to help you tailor those programs. And again, coming down to the importance of assessing the individuals. So where are they weak? Where can they improve? And partnering up with someone to help them address those weaknesses more effectively is a great way to do it. Now, what is objectively wrong with all the treatment, right? So, I've highlighted good treatment practices, that are used for MTSS. I guess the main reason we did all of this, because I haven't mentioned the solution yet, is it can just take too long, is the plain and simple thing. So what we're hoping to do here is not come in and beat our chests and say everyone's been doing it the wrong way. It's about making it quicker. So it takes too long. We've seen Moen et al. And, who I just talked about before, I think with Shockwave, they've shown in an RCT that the average return for 50% of athletes to run pain-free for 18 minutes is anywhere between 102 and 118 days. For 90% of the participants to recover sufficiently to run an 18-minute run, it was over 250 days, right? And these are people going through load management programs. So it's a slow process and it's very frustrating. Now, what I'm hoping to do in highlighting this in this slow recovery is you need to set the expectation realistically for your patients. You need to educate them and communicate clearly that this isn't an injury that's going to solve itself in 1 week or 2 weeks. And I think this and the fact that the injury takes so long to treat is one of the culprits, behind the recurrence of the injury, because patients just aren't being compliant because you're asking them to be compliant for so long and they don't have that education piece. So make sure you're educating them and then you're setting those realistic expectations, and hopefully we can start to see an improvement in compliance. And then also be aware of a term that I personally coined. I'm calling the tinea cream factor. And it's because, with tinea cream, once the symptoms go away, you keep applying for 2 weeks. Too often I keep meeting runners who they feel great. So then they just go, excuse the term, they go balls to the wall again. They go completely committed to their training program and they're back in pain. So you've got to educate these patients that there's a tinea cream factor involved. You can't just go for it as soon as you're feeling pain-free. We need to keep them pain-free with a slow, gradual build.
Okay, just to dive in for a sec. So, and that can be where, when you're talking about the communication and education, where a lot of podiatrists probably may, and especially younger ones, may get themselves in trouble with their patients when a patient has come in with, shin splints, and the podiatrist has dove straight in, oh, you've got this foot problem, therefore you need orthotics. And the patient in their head thinks, well, in a couple of weeks I should be right. But even from this, you're saying 102 to 118 days average to be able to run 18 minutes. So are the podiatrists sometimes giving them false expectations by, hey, spend this money and get this insert for your shoe, and this is going to be the magic pill that's going to fix everything?
Yeah, I think just the nature of the injury, it's a tedious one. So I think with orthotics work really great for patients. So for individual patients, so if you're identifying biomechanical faults the orthotics are going to help address, then that's great. But I think, I don't know, like if I was an athlete, I would prefer to have a quicker recovery than I was told. So I think it's key here to set those expectations for them. And if they recover quicker, then that's a great win for you. Just that communication, and it's not just because they're unhappy if they're still in pain. It's just for the overall treatment of the injury. If you don't communicate the right expectations, they'll go for it right again. And I think that's why we get stuck a lot. I think that's probably going to be a contributing factor to why one of the highest risk factors for MTSS is you've had it before. You've just got athletes and patients in this cycle where they haven't been educated on how to treat the injury properly.
Okay.
So, and then one of the things that came out of our research was there was actually no notable short-term gain. So it takes too long and there was no notable short-term gain. So you as the athletes, you as the podiatrist, as someone who's been a patient for multiple injuries, like horrible injuries for my shoulders and things like that through swimming. One of the best things you can do is set us up so our world isn't falling around. Our world isn't falling down around us. We aren't, experiencing all these negatives. So something to give us a positive outcome in the short term is always a great win. And that's kind of like where those two things, taking too long and not having those short-term positive reinforcers, is why we designed the solution. So the solution, it's a class 1 medical device. It's a lower limb orthosis designed to perform the soft tissue therapy to treat MTSS and other lower limb injuries related to the tightness of the soleus muscle. Now, what we're doing is we're using our counter traction technology that compresses the periostitis at the site of pain for MTSS sufferers, and we're also reducing tension in the soleus muscle for those sufferers and also sufferers of equinus. Now, the rod, which I was talking about, we're compressing the periostitis. We're applying it at the distal 1/3 of the posteromedial tibial border, so the site of inflammation and pain. We've also got the lateral origin, so a node on the top strap at the lateral origin of the soleus muscle, just posterior to the head of the fibula, at the medial origin of the soleus, at the mid-diaphysis of the tibia, and then at the muscular tendinous junction of the soleus muscle and the Achilles tendon. Now, calling back to the periostitis note, so we're seeing that inflammation and that risk factor of decreased dorsiflexion due to tightness in the soleus. It's designed to be worn before or after training for 30 minutes to 2 hours. We actually have no clinical evidence to suggest one is better than the other. I personally am an after training kind of person, but plenty of athletes like wearing it before. So at home at dinner, watching telly, you can walk around the house. And what we're trying to do here is not immobilize the patient. So trying to give them, a tool that's easy to use and it's got high compliance. The key thing I always like to instill, it's an adjunct therapy. So we designed it to be an adjunct. We didn't design it to be a standalone. Load management's the hot dog, and where the mustard is the term I think I used on episode 24. These include a load management program tailored by a health practitioner, a strengthening program tailored by a health practitioner, then also using orthotics or heel lifts where necessary. So if you're more educated than me on the prescription of orthotics and heel lifts, if you identify that the patient is going to benefit from them, please do so. Our device is just one piece in the puzzle with the goal of reducing the time it takes to treat the injury and to provide that short-term positive reinforcement through quick pain relief, reduction in calf tension. We start to hear things like, this makes my calves feel great straight away. So really then giving them that short-term win. So it's all set, it's all good just saying those things. So what clinical evidence do we have? Now, I'm going to firstly present just a double-blinded randomized controlled trial. Now, the disclosure is I'm not the author of this study. Bearing in mind I'm the engineer, one of the people behind the product who's the engineer. So I helped provide the investigational device. And this study was conducted by William McNamara and Dr. Tom Longworth at Sydney Sports Medicine. These are their slides with the permission of one of them to present here. They presented at the 2019 Sports Medicine Australia Conference in the foot and ankle session. I'm going to go through some of them a bit quicker just because we've touched base already on them. Now, if we're looking at previous devices that have been tested, we've seen the pneumatic leg brace in the treatment of MTSS recruits. Unfortunately, there were no positive outcomes. This one is interesting, which affected the actual design of the device, and why if you try one, you'll notice that it's not too aggressive. It's because we saw a randomized controlled trial with a leg orthosis where there was an aluminium, from memory, an aluminium rod that went up the length of the tibia. Now, not only is the tibia border is not straight, so I don't know why they put a straight rod up against it. We saw a very low compliance rate in this study and an ineffective outcome. For me as an engineer, I look at this and go, well, if we're seeing this bruising here and a lack of compliance for us in soldiers, where I can imagine there's a bit more of a push to be compliant, we can't have a product that's too aggressive. Now, and then the other common one we see is this idea of using calf compression sleeves. Now, calf compression sleeves was something I used as a swimmer as part of my recovery. But for MTSS, we're seeing quite a lot of evidence to suggest that they don't have any positive outcome greater than placebo. So the Moen et al. Group conducted a randomized clinical trial assessing the performance of calf compression sleeves. And along with other evidence, it was actually the justification of these researchers to use a compression sleeve like this as the placebo in our clinical trial. Now, the aim of their study was to investigate the effects of the solution, the investigational device, on MTSS symptoms in comparison to a placebo. So how they did it, the inclusion criteria was 6 weeks of symptoms. They were diagnosed on their history and examination in a way that I showed you earlier. Now, the reason for 6 weeks of symptoms was not only to help us, pick a good patient with MTSS. We're looking for motivated patients here. If anyone here has done a sports medicine study and looking at healthy population groups, it's a bit hard, it's a bit tedious. So they were looking for 6 weeks of symptoms to find motivated patients. And then other chronic lower limb conditions, stress reactions and fractures in the last 6 months, any skim or systemic diseases, pregnancy, or anyone under the age of 18 were also excluded from the study. It was double-blinded with placebo, and the participants were randomized, and the data collection and statistics was also completed. So the investigational device was the solution, or a very horrible version of the solution that we made on a college room floor. So what we're looking at here is those sites, which I mentioned earlier, and the periostitis, compressing the site of inflammation and pain. The placebo device actually was our own solution without any of the compressive counter-traction components. So we've got none of these kind of pressure nodes here or the rod. And what we've got here is basically a compression sleeve with graded compression, or a compression sleeve with circumferential strapping. So we've already gone through this a bit. The proposed mechanism of action of the device is fascial traction. So it's looking at mechanotherapy, and then the straps pulling around the inframedial torsion, so reducing tension in the soleus, and then also compressing the site of periostitis. I've just got a question there, Ben, Medical. So indirect, we've also got the bone loading component. So we were looking to increase ankle dorsiflexion, to increase shock absorption through the calves and decrease bone loading. So the device in the study was used bilaterally up to 4 hours per day, pre and post exercise. They completed weekly online questions and were to notify the clinicians if concerned. Now, the online questionnaire was taken from Winters et al. It's a great pain severity measuring tool for MTSS sufferers. A quick Google, you'll be able to find it. And it was conducted weekly over 6 months online. They were also looking at the activity levels, the pain when exercising, walking and resting, device usage, and then also their return to activity as athletes versus non-athletes. Oh, thank you, Bronwyn. I appreciate that. Yeah, I'll get Tyson maybe to share my details if you have to head
I'll just read out the question so that
Yep.
if nobody can see it. It's,
Okay.
Bron was just asking, medical laser is dose dependent, so we'll check what I can. Okay, that's right. So the question was just for you, so that's fine. I'll shut up.
Bronwyn has asked also, what about shoes? And I think I'm not an expert in shoes, but I do believe, I have spoken to a lot of practitioners or podiatrists who've gotten great results with it. And I think it might come down to similar reasons for the orthotics and the silicone heel kind of lifts. So we've got shoes with better absorption, or shoes that are encouraging better gait. So better running gait is probably what I'd suggest there. I might not be right, but I have seen great results with the shoes. Bronwyn, if you shoot me a note, ben@solution.com, I'd love to chat about it. So the load management program, so every patient in device or placebo was given a load management program. So the notes here, patients can progress each stage every 3 days if no pain with or following activity. And they had no more than 2 running days in a row. So i.e. they had 1 rest day out of every 3. If they experienced pain during or after activity or at rest, they had to have relative rest for 24 hours and then continue with the flow chart from a step back, which I'll show you in a tick. And then lack of progression or regression on the flow chart will be reviewed by the doctors conducting the clinical trial. So we start off with relative rest until pain-free walking, and then progressing through. Now we've actually got this distilled in an easier format now, which I'm happy to send anyone if you contact me at ben@solution.com. It's a great little tool, but you've got to remember that every patient is different and they're all going to have different goals. So you use it as a guide to build your own load management. Now, we had 23 participants assessed in the study. We excluded 3 for non-MTSS. Symptoms less than 6 weeks was another 2. And then suspicions of stress reaction and fracture, and then also the unwillingness to participate in the entire study. Now, you might remember my note, trying to target healthy individuals with an injury is quite difficult. We had a lot of people prior to recruitment showing interest, but they would only do it if they were guaranteed the medical device, which is not the way a study can happen. So total participants through the 6 months was 14. Now, the results here, what they basically say is there's no statistical difference between the 2 groups. And again, here, we had highest level of sport, national all the way through to hobbyists in both groups, different treatments. So they were seeing the physio-orthotics and dry needling. Again, we're seeing no statistically significant difference between the 2 groups. Now, the key takeaway here is remembering it was used as an adjunct. We see a typical return to pain-free running in the placebo group. So for the 24-week follow-up, we see them just here getting to 3 out of 10 in pain using the Winters score that I mentioned. But with the solution group, we're seeing a quick reduction in pain and then under 2 out of 10 on the Winters score by week 5, where week 5 onwards, they were progressing through their load management back to full training capacity with no pain by week 5. So this kind of graph here is just a great visual of using the device as an adjunct where you can expect to see the drop. They get those short-term positive outcomes that I highlighted earlier in terms of pain relief, but it still requires them to go through the process and acknowledge that there's a process involved. It's just a whole lot quicker. Now, device usage for both groups, there was no notable statistical difference. So placebo used theirs for 117 minutes for 2.7 days a week, whereas the device used it for 102 minutes for 2 days a week. Now, calling back to the idea of we asked them to wear it for, or the authors rather asked them to wear it for 4 hours a day. They wore it for 102 minutes on average for those 2 days. Between groups at each time, there was never any statistical difference and no difference in terms of usage minutes per week with statistical relevance. Now, there was a lot of factors involved because we were looking at the device as an adjunct. Now, we were fortunate with our partnerships and friends that we've made to make sure we do get a good statistical analysis done. And what we noted that there was we did not identify any other statistically significant confounding factors. So what we've seen with the stats is that the solution between the 2 groups was like the key differentiating factor. So the discussion, we saw the symptoms improve compared to placebo as an adjunct. 6 out of 7 participants in the device group asked to keep their device. Another note that I don't think is here is that in the placebo group, the participants all thought they also had the device. So the device without the nodes, just the placebo. And what we're looking for here and what we kind of proved out is the idea that we can assist podiatrists and physiotherapists treating patients with MTSS. The strengths of this study, it's double blinded with placebo. We've got prospective data. We've got a known and reliable evaluation tool, and we had good follow-up. The obvious limitations, so it's actually the second biggest general population MTSS study with an investigational device ever. Still a small sample, and it's something we're looking to build on. It's difficult to control for loading. We did have a limitation of highly motivated participants, right? And then no long-term follow-up. So we followed them for 6 months. And then one of the other limitations here, which kind of goes into the next study, is we actually didn't assess the ankle ROM or onset of symptoms throughout the study. And every time I say we, I mean these authors. I just get caught up in it. Tyson, did you have any questions there?
I know, just when you were on the podcast, you did mention that the ankle range of motion, the improvement, there was a dramatic improvement wearing the device in the ankle range of motion after a period of time.
Yeah, so we've got to start the next study.
Could be a significant factor.
Yeah, so it was that limitation that inspired us to kind of do the next study. So we've got promising results here, and now it's on the market. Like if you talk to a lot of pods who are using it, they're very happy with how they're using it as an adjunct. We're just making sure everyone's educated and they're providing altogether a better treatment program for patients. Future research we want to do, obviously, larger samples. We want to look at elite athlete and military populations for better variable control. The ankle ROM, future research, which we'll get into in a sec, we've kind of already kicked off. And then looking at things like the incidence and recurrence between seasons. Now, the ankle ROM study, this slide looks a whole lot nicer because it's our in-house slide now. It's not the one taken from the clinicians presenting. So the prospective cohort study, right? So we were looking at, can we improve ankle range of motion to treat? So we're looking to help treat injuries related to poor dorsiflexion or equinus in this prospective cohort study. Now, we did this purely out of request. We had a lot of people asking, well, if this is how it works, and they would try it on and their calves felt good in terms of physios and pods, they were, by how much are we improving ankle ROM? So we did a study with 16 male and 14 female participants. They were randomized to device and placebo. Their legs were randomized to device and placebo, and they wore the devices for an hour. So before they wore it for an hour, we measured their ankle ROMs, and then using a knee wall assessment. And then after they took the device off, we did another ankle range of motion with a knee wall test. Now, with the device, we were fortunate enough to see a 21% improvement average through the 30 participants on the leg that wore the solution. Whereas the placebo, we only saw a 3% improvement. This was hugely statistically significant. So the solution, and now we've seen it out there on the market used for this purpose, we're seeing an improved ankle range of motion in a great way with high compliance, but in this study with an average improvement of 21% just after an hour of wear. Now, what's not said here is there was kind of like a controlled walk. So they were basically sitting down, relaxing, and then went for a walk at a controlled period of time, just to mimic low-level activity. We just want to make sure no one's running in these things. Now, we are trying to grow this on a foundation of clinical evidence. Anyone who's ever interacted with us will know that. We try and say what we know and what we don't and what we're hoping to do. We've partnered with some professional sporting teams in Australia and in Scotland, of all places to have a double, to look at the medium to long-term implications of this ankle ROM improvement. We've also got some teams helping us assess the effects on high-risk players. So those players where they've tried every intervention they can to improve the ankle range, to improve dorsiflexion, and they haven't quite got it yet. It'll be cool to see if the solution helps there, basically. The main focus here is the medium to long-term implications. Sorry.
I could hear your throat starting to go.
Yeah, I know. It was going there. I've been talking since 9 a.m. So to build on our foundations with a focus of assessing improvements in ankle ROM sustained over a whole season, rather than just this acute hour. We're also organising that larger MTSS pathophysiology study here in Sydney. And then after that, we would like to do an additional one assessing the action of the solution on the periosteum. So other possible uses, thanks to the improvement in dorsiflexion. Again, full disclosure, as an adjunct therapy, make sure you're identifying poor dorsiflexion as an indication for the injury. And then also maybe ruling out due to ankle joint stiffness. So looking for, we've seen it used in this case, helping the treatment of tibialis anterior tendinopathy, athletes with high load requirements, so just for general calf recovery. A preventative measure for athletes with a history of MTSS, athletes at season transition points, and now probably the interesting one. Now this point here, going back to our own transparency rule, we've only tested this on relatively healthy patient populations, up to about the age of 55 is kind of where we've now seen it on the market, is plantar fasciitis. Obviously, probably a well-documented thing is poor dorsiflexion leads to a higher severity of plantar fasciitis or a higher risk. And we've seen it used as a good adjunct there. So if you've got a patient who's got stubborn plantar fasciitis, you do a knee to wall, they got a horrible range, it might be a great adjunct to include in their overall treatment. One I actually haven't seen it used on yet. So these top ones I've seen cases of use, just connecting through the literature, is for help with tibialis posterior and FHL tendinopathy. Important here to highlight the contraindications of the device. So we don't recommend it be used for stress fractures. You can use it potentially in the medium to long term. Don't use it for popliteal artery entrapment. Don't use it for chronic exertional compartment syndrome. The side note is we have a few professional teams using it for lateral compartment syndrome, even though we've told them it's a contraindication. The point to highlight there is they haven't done a pressure test to confirm compartment syndrome. It could just be some general exertional pain. It requires us to go into that in more depth. The reason I highlight that aloud is in case you hear of it, just please note that it is a contraindication that we do, we're a device applying focal pressure. I can't imagine it's a good idea to apply focalized pressure when someone's got compartment syndrome. And then as a class 1 medical device, can't be used on pregnant women, anyone with a skin condition, open wounds, or anyone with vascular conditions. Just by doing it the right way, we've been very fortunate with who we've been able to partner with since starting this off. So Dr. Amir Ibrahim, as some people keep telling me, sports physician mafia head, we've seen him use it very well. We've got 2 great physios here from Stephen Nyler from NSWIS and Professor Craig Purdom, who was the AIS physiotherapist of 35 years. And then Talisha Reeve is one of the podiatrists now. Talisha has been awesome in helping us navigate how to correctly prescribe this device. If she ever watches this, thank you, Talisha. But the other interesting thing is I was kind of told by Talisha that if she didn't like it, she would let people know. So I did kind of cross my fingers and send it to her very early on, and she liked it, so that's good.
Yeah, I'm actually talking to her tomorrow. We're doing a podcast recording tomorrow.
Oh, awesome. Well, no, Talisha's awesome. She gave me so much time when we first started, so I really appreciated it. Now, they're $199.95 a leg. They're available through us, through Brigitte, through DBS. Everyone's pretty much got the same price as far as I'm aware for podiatrists here in Australia.
That's the retail price, isn't it?
Yeah, so the retail price is $199.95. I think you'd make about $70 a leg through these distributors, including us. I just would love to highlight to anyone out there who's from New South Wales or looking to make any product, Australia is a really good place to do it. We've been fortunate to be supported by New South Wales Health and New South Wales Treasury to get this up and running. So we're very lucky to have had that support. Just my last ask is just pretty much how anyone out there can kind of help us. We're a young team. I'm only 27. We're looking to build a brand the right way. So on a foundation of clinical evidence, listening to the pods and physios using it. If you're in Australia and you're like an in-service, please reach out with the details you'll see on the last slide. If you want to refer or introduce me to any colleagues, that would be greatly appreciated. But one thing we're looking at now in 2021 is the UK and USA. so obviously different healthcare systems to us. So we're looking for those early stage kind of discussions to better understand the interactions of the private and public health systems and where the solution might fit in. And then also preferred distributors, preferred education providers, and referrals. So if anyone out there can help me with that, please reach out. I'll always do my best to make time for you. So just get in touch. Ben Lindsay, don't have to call me Benjamin, only my mother does that. And my email, best way to get a hold of me is ben@solution.com. So that's it, Tyson, for the slides.
Okay. So if anyone has any last minute questions, I know we've been going just over an hour and we're doing this over a lunch break. So there might be a few people that are chewing on food at the same time while we're doing this. So has anyone got any final questions at all before we wrap it up? Looks like everyone's pretty quiet. Okay. So Ben, thanks for coming on. Well, thanks for doing the podcast with me ages ago too.
That's all right.
I'm gonna end the recording here, and I'll just stop the recording, and we can just keep chatting.
Awesome. No, thanks for that. And then Bronwyn, Marissa, Nesreen, if you just reach out if you have any questions that you think of later. If I didn't answer something as good as you would have liked, that's perfectly fine with me. Please let me know. It helps me as much as I can potentially help you. So please let me know.
I think it's the main thing, people just reaching out. So I'm just going to stop the recording now.